Wagner. And for the next 30 minutes or so, I'm going to kind of give you all of my knowledge in a nutshell on stem cells, kind of the basis behind them, how they work, and what joints they work on, as well as other areas being tendons, meniscus, labrums, but we'll kind of get into all that. I'll give you a little background on myself. I've been in the Seattle area for about 35 years, a little over 35 years, practicing. I was one of the founders of, well, actually the founder of Seattle Sports and Regenerative Medicine, which is where we are now in South Lake Union. I've been here for about 10 years. I was senior partner and medical director of the Sports Medicine Clinic, which was the oldest and largest sports medicine clinic in the country, founded by Keith Peterson about 50 years ago. I was then at the University of Washington for a number of years when they purchased our clinic. Consulting team physician to the Mariners. I'm board certified by the American Academy of Family Practice and Sports Medicine. I'm a fellow of the American Academy of Family Practice and a diplomat of the American Board of Family Practice. So what we're going to talk about today, brief overview now. Synovitis. Basically, synovitis is inflammation in a joint. Osteochondral defects. These are areas of damage in the cartilage, the Teflon covering of the joint that goes down to the bone. Osteoarthritis is when these osteochondral defects basically become widespread, although there's a difference in the etiology between the two. Meniscus tears, labrum tears. Labrum is basically the meniscus of the shoulder and the hip. Partial ACL tears, rotator cuff tears, chondromalacia, which is damage to the cartilage, but not to the point yet where it's damaging the underlying bone, and tendon injuries. Okay, first we're going to talk about osteoarthritis, which is probably what we treat more than just about any other condition. So these are some pretty horrible looking knees. This actually was a patient who I did 9 or 10 years ago. Pretty awful knees, was told that she needed total knee replacements. Hadn't seen her for 9 or 10 years, came in to see me for something else a few months ago. And I took a picture of her knees and they still look pretty awful, but she is pain-free, back to full activity, doing the activities that she enjoys. Basically, osteoarthritis is damage to that Teflon covering of the joint. So, when you break a chicken or a turkey drumstick off that white glistening surface, it's damage and where that surface gets destroyed, and you basically starts out with cracks and then fissures and craters and thinning of that cartilage. There's also a very significant amount of inflammation associated with that, which causes pain and swelling. We see osteoarthritis in many joints. The knees were the ones we had just looked at. This is in the midfoot, and basically we're looking right here at the joint between the talus and the navicular. We can see arthritis in the midfoot. We see a significant amount of arthritis in ankle joints. A lot of osteoarthritis in hips and in shoulders. Thumbs, base of the thumbs, which is called the first CMC joint. Wrists, as far as be old traumatic injuries, or it can just be a genetic predisposition to arthritis. Sacroiliac joints, lower back areas are all amenable to treatment with biologics. So if we move on to a more localized area, osteochondral defects, or OCDs, we mostly see in the knee and the ankle. Oftentimes they're associated with trauma, and we see them in younger patients. Well, I say younger, it could be anywhere from, 13, 14 up till 30 or 40, or even later, but they're more common in younger, active, healthy patients. And it's damage basically in a focal area to the cartilage down to the bone. Meniscus tears, for 50 years, we've been treating meniscus tears by just taking them out. Well, there's a reason that we have meniscus in our knees, and it's to provide cushion and support for the knee joint. So we like to leave them there if we can and heal them rather than just cut them out. Now, meniscus does not have a blood supply. So, except for the very, very, very outer 5 to 10%, which is a very small percentage of tears. So, they're not, you can suture them all day long. They're never going to heal. The only way you can get meniscus to heal is by putting a blood supply there, which is what stem cells do. And it's a very concentrated amount of a very highly specialized cell that can regenerate new cartilage. Labrum. Talked about earlier, labrum is the meniscus of the hip and the shoulder, except it varies a little bit in its structure. It's more like a rim of cartilage that surrounds the joint. And it's like a gasket, or I picture it as kind of like one of the rings of Saturn. And it definitely provides stability in the shoulder and in the hip. The shoulder and hip are very unstable joints. That's why they have this great range of motion. So oftentimes people will get tears in the labrum. Once again, it's not something that you just want to go in and just remove or tack down with staples or do surgery, because possibly you can get issues from that. You can get issues with instability. You can get postoperative pain. You can get scar tissue. And so these lesions in the labrum respond very well to biologics, because we can, once again, we can put a blood supply there so that we can heal the damage to the labrum. ACL tears, anterior cruciate ligament. Um, Partial ACL tears, I treat all the time with stem cells. They do extremely well. Complete ACL tears, I pretty much send to the surgeon. However, I've had 4 patients, well, actually 3, but one has had 2 knee joints done, who were complete ACL tears documented by MRIs, who refused having the surgery because 2 of them are MMA fighters. They're women, and they're all women, the ACLs. Women tear more ACLs than men because they have a very narrow tunnel where the ACL goes. And the other was a Nordic skier from Norway who's an Olympic silver medalist. And they basically understood that after urging on my part, to have the surgery. They did not want to have the surgery. They wanted to go ahead with the stem cell procedure. Subsequently, all 4 of these patients have had complete healing of their ACL tears and are back to MMA fighting and skiing with no pain and no instability. However, to me, there's still not enough data out there to recommend treating complete ACL tears with stem cells. If they're partial tears, there's still a blueprint there for the cells to regenerate the tissue of the ligament. Yeah, this was one of the patients who basically the middle portion of this, the angled forward, is the anterior cruciate ligament, completely torn. Maybe I can convince myself there's a few fibers there. So that's kind of what I'm thinking. It's almost like there's a blueprint for the cells to lay down new ligament tissue, new collagen there. Rotator cuff tears. Okay, so rotator cuff tears, once again, partial tears. If somebody has an injury and they come in and they can't lift their arm up, then I'm going to talk to the surgeon and have them repair their rotator cuff. Because if it's a complete rotator cuff tear and they've got significant disability, those stem cells are not going to bridge the gap to completely heal that rotator cuff. However, partial tears and also chronic tears that have been present for years or months even, and that have retracted and atrophied so that they're not possible to get them back together surgically. So with stem cells, we're not even going to be able to get them back together but we can decrease the pain and increase function with stem cells. Now, for partial tears, stem cells is definitely a much more percentage-wise, it's a much better way to go than partial or surgery for partial tears. Surgery for partial tears, because the tears basically occur in an area of the tendon called the avascular zone, has a really, really poor blood supply. So if you put sutures in, you compromise the blood supply even more, and 60 to 90% of surgeries for partial rotator cuff tears fail within 5 years. Um, However, stem cells for partial tears, we're looking at patients, depending upon the actual patient and what else is going on in the shoulder, 75 to 90% of those patients have incredible return to activity and improvement and loss or diminishing pain. Chondromalacia, this is most typically behind the kneecap, and it's where you get damage to that articular cartilage. That's the Teflon covering of the joint, but it hasn't yet gone down to start to affect the underlying bone. Um, Typically runners, more so women than men, because they have typically kind of abnormal tracking sometimes in their kneecaps because women have wider pelvises than men and they have more of a knock knee type approach so that the patellas like to ride to the outside and they track abnormally, thereby kind of destroying some of the cartilage behind the kneecap. Um, Runners, women runners, see a ton of this, and it usually doesn't involve the weight-bearing portions of the joint. It's pretty much just behind the kneecap, and these patients do incredibly well with biologics, which is when I say biologics, I'm talking stem cells. Tendon injuries, Achilles tendon. Once again, complete Achilles tendon tears, I send to the surgeon because we're not going to bridge the gap with stem cells. However, partial Achilles tendon, patellar tendon injuries, we definitely treat with stem cells, and they do incredibly well. Um, yeah, this was a patient who basically, if you look, the top portion of the tendon, which is the dark gray, is intact, and then you see this white fluffy stuff behind. That's a complete, actually, his was there's still some on his MRI images. There still is some fibers intact, and he did not want to have surgery. I think he's 80-year-old tennis player, and did stem cells on him. He's back playing tennis. And this is actually a guy who is, I think he holds the right. He's had 9 different joints done with stem cells. He's like a poster child for stem cells. He used to play a lot of tennis, still plays a lot of tennis and golf. I think he's like 82 or so. Synovitis is just inflammation in the joint. And there's this like feathery tissue that lines all joints. And sometimes it just gets inflamed. Now, when I see patients with just synovial irritation, I'll usually just do something called PRP, which is platelet-rich plasma, which basically stimulates a healing response and ultimately decreases inflammation. I'm not trying to regenerate anything in these joints. We're just trying to decrease that inflammation. And if physical therapy and ice and anti-inflammatories don't do the trick, then going with the platelet-rich plasma is a good option. It takes about 15, 20 minutes. Okay, so let's talk about how these great little cells work and what are stem cells. So regenerative medicine is the field of study that utilizes stem cells to heal and regenerate damaged tissue. It's the use of autologous, meaning from your own body, adult mesenchymal stem cells to regenerate bone, cartilage, muscle, and tendon. The stem cell is an undifferentiated or unspecialized cell in your body that has the ability to renew themselves and to transfer into cell types within the body. We only want one particular stem cell. It's called an adult mesenchymal stem cell. The reason being they can grow up to be muscle, tendon, cartilage, and bone. We don't want anything else. Those are the ones we want. And by virtue of a very complex software program that runs our centrifuges, we can isolate those cells in billions and then be able to inject those into the joint. And we'll talk about the actual procedure part in a little bit. So what is stem cell therapy? This is a quick little, it's kind of like a cartoon, but it gives you a good basic information. It lasts about 4 minutes, so I'm going to start it now.
What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and ridges. It is used for arthritis and injuries to ligaments, tendon, muscles, cartilage, and vein. Let's look at the difference between human and living stem cells and embryonic stem cells. Embryonic stem cells
I think it'd feel louder.
mean that they
Are you turn on podcast thing?
choose a venom different.
Can you make it louder?
The other thing, blood stem cells are maybe not, meaning that they prevent the red cell will no longer and kill and thus safely refer from the cells. We think our new guys stem cells. What in the world are these stem cells? To understand this better, let's look at this for Jane. Your house is exposed to different elements.
Yeah. So get now.
Gems. Wind,
There we go.
fire, rain, sun, and time. All cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and the contractors to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. Stem cells work with the concept that, in addition to giving instruction for repairs and maintenance, transform to specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there's a balance between damage and repair. You have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than the ability of your body to repair it. This leads to an imbalance and ultimately leads to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job. Or sometimes the amount of damage is too much of available stem cells. But fortunately, there are areas of the body that keep a good number of stem cells. These areas include the bottom of the hips and the fat in your abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that did not include with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Okay, so just to kind of reiterate some of the things that we found out about in this little cartoon was that when you were 10, when we were 10, one out of every, basically 2,000 cells floating around in your bloodstream was a stem cell. Actually, I had one out of every 200. When you hit 60, it's one out of every about 200,000. But there's still these areas in your body, basically being bone marrow and fat, where you have very, very high concentrations of stem cells. So even I mean, we've done over 500 patients in their 90s, and we've actually done two patients who are 103, who are friends. One came in, had both her hips done, and was so thrilled she brought her friend in to have her hips done. Um, so we can get still a very large number of stem cells. Now, I know one of the things, there are people out there who use allografts, in other words, stem cells from elsewhere, and they buy them. You can buy stem cells online, and they claim, oh, if you're 60 or 50 or 70, you don't have enough stem cells. And these are usually clinics that chiropractic clinics, naturopathic clinics that hire nurse practitioners to do the injections because they're not allowed to do it. They buy stem cells online, pretty much comes from south of the border. There are no live stem cells in that product, and God only knows what else. So beware, and I will talk about that a little bit later. Um, so we probably do more knees than any other joint. And I have so many patients who come to see me because they don't want a knee replacement, or they had a knee replacement on one knee and they're miserable. And or they get referred to me by their surgeon because they're not candidates for knee replacement. Either maybe they're significantly obese, or they've got congestive heart failure or COPD, or some reason why they would not be a good surgical risk. So basically, total knee replacement, big data, 65 to 70% of the patients are satisfied with the results. Problem with that is that means 30 to 35% of patients wish they'd never had it done. And the pain can be worse afterwards. I've seen many patients who've had not only complications, but worsening pain. I probably see 3 or 4 patients a month who come to me because they had a total joint done a year or 2 or 5 ago, and they're absolutely miserable and they want me to do stem cells. I said, well, there's nothing I can do now because all you got in there is metal and plastic. It's a big surgery. It's a year of rehab. You do need help. There basically are a number of complications that can occur. Number one being infection. Number two being blood clots in your calf and your thigh that can go to your lungs, which is a pulmonary embolism. Heart attack and stroke. It's a big surgery. There's a lot. Basically, we're amputating a joint. There's a lot of bleeding. Subsequently, there's a lot of clotting. Sometimes some of those clots make their way back to the heart and the brain. A knee is going to last, and depending upon your size and how active you are, anywhere from 8 to 15 years, and then you have to have it redone. And the redos or the revisions don't do usually as well as the first one did. Um, there are studies out there that suggest that there's an increased incidence of dementia with total joints, not just total knees, but it's because of metal, and it's chromium, cobalt, nickel, and titanium that make their way into the bloodstream and then to the brain. Also, if your BMI is over 30, that puts you at increased risk for all of these complications. Um, Actually, this was I just talked to a bunch of the Washington State meeting of the foot and ankle surgeons, so we don't need to talk about this. That's ankle arthroplasty. But what do we do before the procedure? It's not a big pre-operative. This is not surgery. So basically, we tell patients stop anti-inflammatories if you're on any, like ibuprofen, Aleve, Advil, um, turmeric, or prescription anti-inflammatories. We like people to drink a lot of water for a day or two before the procedure, so it makes the blood draw easier. The only medications that we basically talk to patients about is if they're on blood thinners. So say somebody has atrial fibrillation and they're on a blood thinner. Most of the time, we usually just stop the blood thinner for a day or two and do the procedure, and then you start back immediately after the procedure. We've also done the procedure with patients that could not go off the blood thinners. We just talk to their prescribing physician, and sometimes we can do something called the Lovenox bridge, which enables us to do it and doesn't put the patient at any risk. We do give patients medication prior to the procedure for pain. Some patients decide to go without it and just go with Tylenol. The procedure itself takes about an hour. Basically, what we're doing, first we draw blood. From blood, we get platelets. Platelets are these great little packages of growth factors, cytokines, exosomes, anti-inflammatories, and basically when done in combination with stem cells, they're fertilizer for stem cells. We then do bone marrow extraction. And this is the big thing patients are always worried about because they've heard horror stories about it. The area that we take the bone marrow from is called the posterior iliac crest. So basically, you've got your spine and your low back, and then you've got the pelvis and the low back. That's where we go, is to the top of the pelvis. We're nowhere near the spine. We numb the patient up, go down to the bone using a specialized needle called a Jamshidi needle, go through basically picture the bone as a chocolate covered malt ball. We go through the chocolate covering down to the malt and withdraw the bone marrow. It takes me, I've done 20 some odd thousand of these. It takes me less than a minute to do a bone marrow aspiration. I would say pretty much half, 50% of patients are like, are you kidding? You're done already? And the other 50% are like, oh my God, wow, that feels like sciatic nerve pain, or it feels like a deep hollow ache that I can't even describe. But if you're in that 50%, it lasts about 30 seconds. As soon as that needle is out, the pain is gone. We then do a mini liposuction, kind of right in the love handles area, which we numb you up. You don't even feel that. So we get stem cells from bone marrow, stem cells from fat, goes through this whole process whereby we isolate just those particular stem cells that we talked about earlier in billions. We're then going to get a few trillion platelets from the blood draw, which we isolate as well. Everything is done sterilely. Everything that the bone marrow and the fat and the blood touches is heparinized because it clots very quickly if it's not heparinized. And then we take those 3 separate syringes, and then using ultrasound guidance, we inject those back into either the tendon, the muscle, or the joint that we're treating. Who do we not do the procedure in? We talked about blood thinners. We have ways around that. If somebody is actively being treated with radiation or chemotherapy to the pelvic area where we take the bone marrow, we're going to at least have a conversation with their oncologist before we proceed on with that. And if somebody's got an active infection, they got pneumonia or they got cellulitis or sinusitis, we're going to want to treat that and hold off on the procedure. This is something I just touched on earlier. Do not see some of these groups out there that are buying stem cells online and treating patients with it. I have seen some horrific stories, infections, patients who went to Mexico and had the procedure and are in worse pain than ever. We actually had one patient that we had to do an above the knee amputation on because of a horrible septic joint in their knee that after 3 months of antibiotics could not be brought under control. So be careful, and you'll see these people advertise a lot and they say, oh, don't use your stem cells. You want to use embryonic or amniotic or Wharton's jelly. I would steer clear of these people. You want to go to somebody who's done a ton of them and is board certified and has trained in this for years and years. So patients who have mild to moderately severe osteoarthritis, big data says 85% of those patients obtain at least 80% improvement. In our hands, and we've done a little over 20,000 patients, 91% of our patients are at least 75 to 80% improved. So basically, the nice thing about biologics, stem cells, there's no downside. So the worst case scenario is you fall into that 9% and you say, doggone it, it didn't get that much better. I mean, I'd love to be able to tell patients it's 100% slam dunk guarantee, but it's not. But the nice thing is people do not get worse. Anytime you put a needle in a joint, yes, there is always a risk for infection, but knock on wood, I've injected literally hundreds of thousands of joints without ever seeing an infection. I'm going to just kind of briefly go through this because oftentimes patients see their surgeon or somebody who says there's no data, there's nothing to say stem cells work, and well, they wouldn't be doing them at Mayo Clinic, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, Kerlan-Jobe, Stedman, at all the major research places in the country if they didn't work. So basically, this is from Advanced Biomedical Research. This is pretty much on PRP to treat plantar fasciitis, and this is still from that lecture I did for the foot and ankle surgeons. And this was also with chronic plantar fasciitis, which I treat quite a bit with platelets, PRP. However, if there's an MRI documented tear in the plantar fascia, I will do stem cells along with the platelets. And we talked earlier about these osteochondral defects, the defects in the cartilage and the bone. And this is a study from the bone or BMJ 2020, which said this was a 42-year-old man, had this osteochondral lesion. He ended up having stem cells, and mapping and MRI showed successful regeneration of cartilage. These are what OCDs look like. This is a on the left is a magnified view of that osteochondral defect. That should be a nice smooth dome right there. That should be white. Instead, it's kind of gray and has a kind of a couple loose pieces in there. Once again, repeat analysis of MRI at 24 months showed regeneration of cartilage over the site of the osteochondral lesion. The Journal of Bone and Joint Surgery said there was evidence of meniscus regeneration and improvement in pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for the apparent knee tissue regeneration. And this is an orthopedic surgery journal. Once again, from another orthopedic and surgery journal, the versatility of stem cells as a treatment modality has landed it another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate pain experienced by osteoarthritic patients. From Helion, this study showed a single injection of bone marrow stem cells provides long-term benefits. The procedure is simple, fast, well-tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. From the Journal of Orthopedic Translation, another orthopedic surgery journal. In contrast to traditional treatments based on drugs, proteins, or antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs, such as osteoarthritic joints. From Nature, which is basically the British New England Journal of Medicine, in conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without severe adverse events. Cartilage mapping by MRI showed evidence of improvement in good cartilage quality and significant decrease in poor cartilage quality. So there are many, many studies out there. And here's another orthopedic journal that talks about significantly alleviating pain experienced by osteoarthritic patients. And these are, once again, I have a lot of studies that we put out there and we have in our on our website and also in our brochures. So extremely safe procedure. Now there's probably greater than 50 or 60 million cases done in the United States with zero, as long as you use your own cells, zero side effects reported on the FDA database. And once again, no general anesthesia. It's local anesthetic. You're awake, you listen to music, You walk out. You do need a ride, however. Um, After the procedure, basically, we don't ice it, but we do rest it, compression elevation. But most people are walking around, you're doing your activities of daily living. We avoid anti-inflammatories for 6 weeks because that's how the body heals, by inflammation. So we want inflammation for that first 6 weeks. So no anti-inflammatories for 6 weeks. We kind of avoid alcohol for 6 weeks, but we do start on physical therapy within a week and then start getting patients back to activity as quickly as we can. So that's my end of the procedure. What I'm going to do now is have one of the physical therapists, who is the head of our RET clinic here at this office, talk to you about kind of how she rehabs these patients. Then I will be back on to answer everybody's questions for whatever amount of time we need to take.
It's all right. Okay, looks good. Okay, perfect. So thanks for having me, everyone. My name, just giving a little bit of background of myself. My name is Lindsay Bond. I am a physical therapist. I'm a doctor of physical therapy. I'm a board certified orthopedic clinical specialist, which means I've done residency. And then I'm also a fellow in training for orthopedics and manual physical therapy. So basically, the point of what I'm wanting to do today is just talk about very, very quickly about what does physical therapy look like after regenerative medicine treatment. So the role of physical therapy. So obviously, regenerative medicine sets the stage for healing. My job is to guide you guys through the recovery process. Our focus is to restore mobility, strength, and functional independence because you've probably been in pain for a little bit at this point. And I bridge the gap between that biologic repair and real life movement and getting you back to doing the things you want to be doing and what you love to do. Making sure that I have an individualized rehab program ensures tissues adapt safely to the new stress as that biologic sets into the joint. So why does physical therapy matter? We prevent stiffness or weakness during the healing phase. Kind of like Dr. Wagner said, we want that inflammation. We want it to become inflamed for that healing process. And then I prevent that stiffness from happening and start working on small stabilizer muscles. I facilitate a safe and progressive loading to support tissue remodeling, let it do its job. Optimize the success of that biologic through movement re-education, and then promote confidence and return to meaningful activities. Okay. So this is a quick, just basic overview of what does rehab look after regenerative treatment. So like you said, about 5 to 7 days after you get the injection, that's when you come and see me at the clinic. So phase 0 to 3 weeks is what I call it the protection phase. I help control pain and inflammation in terms of appropriate or inappropriate. We avoid excessive load in the beginning, let the biologic do its job, gentle range of motion, and a lot of it is just patient education. What can I do correctly now, and what do we need to wait on? After that, in the 3 to 6 weeks phase, we restore that full range of motion, especially as that inflammation comes down at that 6-week mark. We start to activate small stabilizer muscles, address asymmetries, because again, you've probably been in some type of pain for a prolonged period of time. We probably have some asymmetries that we need to address, and then introduce some light strengthening. At that 6-week mark, you'll have a follow-up with your doctor, and then we'll get cleared to start doing some more functional strengthening. So at that 6-week mark, we're increasing tissue tolerance, building strength and coordination, and integrating full multi-joint movements and prepare for more functional demands, whether that's at work or that's your leisure activities. And then 8+ weeks, depending on how much physical therapy you need and how things are feeling, we'll do sport and work specific movements, power, speed, endurance training, building confidence, and focus on not injuring ourselves again. And then again, everyone's body reacts a little bit differently, depends on the tissue type, and then what your guidelines are with Dr. Wagner. So just some examples of PT interventions. Like I said, I'm a manual physical therapist and orthopedic board certified. So we have targeted manual therapy treatment to guide and restore your mobility. Neuromuscular retraining, which just helps improve that joint stability, especially talking about the hips and the shoulders, like you said, are unstable joints. So working on that stability and movement control. Progressive strengthening and endurance training, working on your walking patterns, your balance, and your functional movement. And then again, education on pacing, posture, and long-term recovery. As always, obviously collaboration is key. I talk to Dr. Wagner. Dr. Wagner talks to me. We have close coordination between physician and the PT ensures safe progression. Rehab plans should align with the injection site and the healing timeline that it takes. Communications help manage flare-ups and setbacks early if that happens. And then patients give feedback about how things are feeling intensity-wise and our readiness to progress to the next stage. The evidence, obviously, he brought up the evidence of the stem cell and the PRP in a more solo and isolated. So there are evidence and studies show that improved function and pain reduction happens at a higher rate when physical therapy follows stem cell and PRP. Exercise enhances stem cell activation and that tissue remodeling. So basically, you took this time to get the stem cell and the PRP. Exercising on top of that just boosts that even more and you get better results from it. Lack of rehab can lead to stiffness and sometimes some poor long-term results. But again, we're working on a lot of those asymmetries that you might have had before as well to make sure that this biologic is getting the best bang for your buck. And then active recovery yields better outcomes than rest alone, and that's almost in any diagnosis. And there's lower re-injury risk and more durable long-term results. So the key takeaways is essentially physical therapy is essential for maximizing stem cell therapy, and that's why Dr. Wagner refers to physical therapy after these injections. Movement and gradual load are safe and necessary for healing, and then every plan that you have with your physical therapist should be individualized. There should not be a one-size-fits-all rehab because you're a different person who has different pain and different activities that they want to return to. And then consistency, patience, and obviously professional guidance really do make the difference when it comes to this biologic injections. And that's it. That's my references for the slide. I know this is mainly Dr. Wagner, but if you guys do have any questions, feel free. I'll stay on for the Q&A as well. And then if you have any other questions, I am happy to join. But thank you for having me, Dr. Wagner.
Thanks, Lindsay. So am I on now?
Yeah.
Okay. Is John?
Still here? You can ask him.
Yeah,
So
you want me?
Hey, John, how are you?
Hey, Dr. Wagner.
Well, John had his hip done about 3 months ago, and he happens to be here. He's going to tell you all about it.
See, look at me. You told me I had to do that. Doctor, it hurts when I do that. Then don't do that. Yeah, the worst news I ever got, Dr. Wagner, was I think it was probably 7 years ago when this doctor said to me, "Well, your running days are over." And this story that I have is applicable to anybody that's like, oh, I'd love to play golf or tennis or pick up my grandchildren. And when somebody tells you, well, that's it, you can't do that anymore, you all of a sudden after it hits you, you realize, wait a minute, I'm not a runner, I'm not a baseball player, I'm not a tennis player, I can't jog, I can't swim, I won't be able to. It's a giant part of your life is all of a sudden just taken from you. And so for 7 years, no running because the doctor said you can't run, and I had a whole bunch of pain. And then if I did try, I wouldn't be able to sleep at night. And then I was the old guy. My wife's like, "Why do you have to put a pillow between your knees?" Every single night, I was unable to get a good night's sleep. And this went on for the last 2 years. It got so bad. And I went back to this doctor. Well, looks like we're going to have to give you a whole new hip. And I was like, well, what is that going to involve? He explained it to me. So what I did is I started looking around. I talked to some people about it. I talked to Bob over here at Cairo Sports and 710 Sports. And he told me all about you. And I asked him about it. And he's like, oh, it's amazing. It's amazing. He goes, you're going to feel the next day, you're going to feel like you was never anything ever bothered you. I was like, one day later, and I asked you about that. You said that's not the case for everybody, but you will notice right away the inflammatory nature of it. But it sounds like a bad thing. But actually, the next day, I even said on the radio. I think 2 days later, I went for a run, and you called me. You're like, no running, no running. 6 weeks, take it easy. No heat, no ice. Just take it easy. Come on back in again. And I've been talking about on the radio that I ran for the first time in 7 years just last week. I just did a little easy, like you said, nice and simple. I only did a mile and a half. But you have to understand something. That to me, it was like all of a sudden I just felt like I've got this giant part of my life back. Because the exercise wasn't just the miles, it was mentally what it does for you. And I am just such a believer. I tell everybody. In fact, I try to steer every conversation over. You got bone on bone, no matter who I'm talking to. Because and I've done more research after you've turned me onto it, and the science is so advanced. If somebody told you, "Well, I had that 20 years ago, it didn't work," as you were talking about earlier, Dr. Wagner, this thing leaps and bounds on how you're able to get the amount of cells in there. I think you told me you took 600 billion out of me or something like that. You said I was a little younger, you could have gotten a trillion, whatever the number was. I got to tell you something right now. I am a believer. I just I can't I can't say enough good things about it. Really, you my life feels complete because I've got that part of me back as an athlete, as somebody who can lift weights again. I'm just waiting for you to give me the okay to deadlift, and it's the best. Really, thank you,
Hey,
thank you,
I love
thank you.
hearing that. The favorite part of my day is when I see patients in follow up and I hear all the stories. Hey, I just got back from, Kilimanjaro, or I got back from the Himalayas, or I'm playing tennis, or I walked 36 holes, and I had no issues. And I mean, back swimming, back golfing, and people get their lives back and they don't have to go through big, surgeries. And so that's the best part of my day, when I hear the stories of what people get back to, and yours is
Yeah.
great. I love hearing that.
Yeah, it's I'm going to sign up. I know you do. I don't know if you signed up for that Ironman with your kid yet, but my daughter keeps, Dad, are you doing a half marathon? Are you doing a half marathon? It's like, Charlie, you're 24. I'm 63. She goes, oh, you can hang with me. And I'm like, if I could cross the finish line with my kid, that would be the greatest feeling.
It is. I didn't cross the finish line with my kids with Ironman, but we were kind of staggered at different places. My son is like an Uber athlete, and my daughter, it was her first one, but we all did the same ones together. We did two of them last year, and it's a fun thing. It's great to be able to do
Yeah,
that with your kids.
yeah.
So,
Well, that's all I got to say. Unless you got anything else for me, I'm going to go get some dinner. I just finished a long 3 hours of blabbing on the radio.
well, good. Well, I love hearing your story, and I'm sure I'll see you soon at the office.
Okay, I'll be in there for you. Thank you, Dr. Wagner. Appreciate it.
Take care, John. Good seeing you.
Bye-bye.
All right, so now we'll move on to everybody's questions. Um, Chelsea's gonna read them to me, and I'll do my best to answer them right now.
All right. So the first question comes from Jim asking, is this a treatment for post-chemo joint pain and shoulder pain?
It all depends what the joint looks like. Um, if there's damage to the articular cartilage, if there's synovial damage, then yes, as long as we're not still in the process of undergoing chemotherapy or radiation therapy. But yes, I've actually treated a number of patients with diffuse arthralgias unfortunately, from chemotherapy.
He also asked, avascular necrosis damage, repair, and return to activity.
So it depends on the degree, if there's collapse or not. I think we're probably talking about hip, I would imagine. But I treat a bunch of patients with AVN, and they do very well. Now, I can't guarantee that it's going to take care of the joint forever, but can we buy you some time? And like I said, it's individual. It all depends what those images look like.
Next one is from Lavanna. Can stem cell replacement be used for TMD or TMJ?
I really want to do TMJ. It's about the only joint I have not done yet. And there's not a ton of data out there. I probably wouldn't do stem. I probably would just do PRP. It's a very small joint, but oftentimes there's a disc of cartilage in that TMJ, and sometimes the disc gets damaged and you get inflammation in the joint. So I'm waiting to see patients who have TMJ to do that. I haven't had the opportunity to do it yet.
We have a few patients asking about insurance coverage.
Unfortunately, the procedure part itself is not yet covered by insurance. I ski every year with these guys who are on the board at Regents, and apparently it's not even on their radar screen. A lot of politics involved with it because of total joints. Total joints make hospitals, lots and lots and lots of money, and they don't want to see that go away. So it's not covered by insurance. The only authorizations for stem cells as of yet are wound healing, burns, leukemia, and lymphoma. Um, Now, if a lot of times patients have like a HSA or an FSA, like health savings account, flexible spending account, and then they can usually use those for the procedure.
Uh, Christina asked if a patient has von Willebrand's, does this complicate the outcome of this procedure?
That certainly would be a conversation with the hematologist as to what exactly cell counts are, CBC, platelet counts. Um, but I don't think that would be, I mean, off the top of my head, I don't think it would be a contraindication to the procedure, but I would talk to your hematologist on that.
Okay. There are several people asking about backs and nerves for stem cell.
So I do not do spine. I'm just too busy with joints here. And the other thing is with spine, you have to have a dedicated lead-lined room and a C arm, which I do not have here. For certain disc problems, stem cells work relatively well. The data is not as robust for spine as it is for joints. I do have some people that I refer to down in California, Vegas, and Portland who do spine, however.
A couple of people asking kind of process-wise in terms of diagnosis, like for candidacy for the procedure, and then how many joints can be done at one time.
Sure. Um, Basically, we have patients usually just make appointments for a consult. If they've had images within a year, they bring their images in and the reports. I like the images and the reports. And we kind of take a look at everything. Physical exam, looking at the images. If we don't have new images, we can do them here. And then it's just a matter of discussing, what the percentage is. If I think your joint is totally devoid of cartilage and not a good candidate, I'm going to tell you that. I just did a lady's knees the other day who came in from somewhere far away. I can't remember, but she had bad arthritis in her hips. Hip joint surgeries do better, way better than knee joints. And her hips were pretty much, no cartilage there. I said, go have the hips done and we'll just do the knees here. So that brings us to how many joints can you do at once? We can do 3 large joints at one time. That's the most, because when you get past taking 100 cc's of bone marrow, you start to get diminishing returns on the stem cells from one draw. So that's why we cut it off usually at 50 cc's from each side. So 3 large joints is kind of the maximum that we can do at once. Now the nice thing about doing more than one joint at a time is it does save you a significant amount of money because the big expense is in the surgical kits. So, whereas one joint, maybe, 8,000, 2 joints be like 11 and 3 joints like 15 or 16. So it does save you a lot if you end up doing more than one joint.
Let's see. Questions about osteonecrosis and stem cell.
So osteonecrosis, which is kind of very similar to what I just talked about, AVN. Avascular necrosis or osteonecrosis is where the blood supply to a particular area of the bone just stops or dies, and the bone ends up dying. It all depends. Is there collapse? How big is the area? What the joint looks like? So certainly, worth a consult and looking at images to be able to determine.
What are the benefits of using your own stem cells for a 50-plus-year-old versus embryonic?
You do not want to use embryonic. The reason being, those stems, that's chiropractors, naturopaths, they do that because they're not allowed to do any of this procedure. They're not even allowed to do the injections. So they hire nurse practitioners They buy stem cells online. You can buy them online at home. If you Google it right now, you can buy some. They come, most of them from south of the border, from women who are willing to sell their placentas. It is a sketchy patient population. No live stem cells because it's a desiccated white powder that you just add sterile saline to, and then they have their nurse practitioners inject it. So, yeah, you want to steer clear. And the fact of the matter is, at 50 years old, depending upon how big you are, how tall you are, we're still going to get somewhere between 2.5 and 4 billion mesenchymal stem cells, which is more than enough. Because of the system that I use, which is out of Florida, but was developed by a buddy of mine who ran the molecular biology department at UC, University of California. We're able to get so many more cells than we could get in the past, and of that particular type of stem of cell.
Is this procedure useful or an option for fingers, and how often is that done?
Yeah, more so thumbs, base of the thumb, wrist, and then the small joints in the hands. Once I get to the small joints in the hands, I usually just do PRP. But for CMC joints, base of the thumb and wrists, we usually do bone marrow and PRP. And it works I actually have arthritis at the base of both of my thumbs. I had stem cells to both of them about 9 years ago, and it was just a game changer. Just amazing results.
Tim asked how long, in terms of years, is the procedure successful before it needs to be repeated?
So it varies. We have Bornstein at Harvard's been doing this 20 years, got patients out 20 years, doing just fine. We also have patients who've come. I had a guy come in, came in a couple months ago, who we did his knees. He's a big guy. He's a ex pro baller, and he does a lot of downhill mountain biking. He had really bad arthritis in both his knees. The first thing he said to me when I saw him in the exam room after 10 years, he was there with his wife. He said, "Doc, do you remember what I told you 10 years ago when my wife dragged me in here?" He goes, "I looked at you, I said, this is voodoo. This is bullshit. There's no way this is going to work." He said, "I got to tell you, I've referred over 20 patients to you, one of whom is my son, who they're all doing fantastic." He goes, "My knees are starting to bother me a little bit. I don't want to do knee replacement. Can we repeat it?" So yeah, we can repeat it. Not a big deal.
Someone also asked about carpal tunnel.
Carpal tunnel, if steroid injections and physical therapy don't work, I'll try PRP. But stem cells, it's nothing we're trying to regenerate in a carpal tunnel. We're just trying to decrease that inflammation.
Someone asked if they can still get the procedure on their knee if they are a smoker.
Yeah, I mean, I prefer you not to smoke because your healing will be better, but we have smokers that we do the procedure on. I don't want you smoking during the procedure, though.
Jamie asked if they're out of town, what does the appointment look like, and how does physical therapy work?
Sure. So we have seen, I actually was telling my younger son about this the other day. We have seen patients from every continent. We do consults on telemed or Zoom. We have the patients get imaging and send them to us ahead of time so that when I see them, I've already been able to see their images, and then we can do an online consultation. Patients fly in all the time, have the procedure done. They can fly out the next day. Some fly out the same. We see a lot of patients from Canada who come on Lake Union Air because it's right behind our office, or Kenmore Air, whatever, and have the procedure and jump back on the plane, go back to Vancouver, Victoria, whatever. So yeah, a lot of that can be done on telemed online, and then Chelsea or anybody can set up the procedure and tell you about hotels that are right next door and different things to make it easy.
Christina asked, do you have any patients who have had a reverse Bankart tear in the shoulder and have stem cells helped?
A reverse Bankart tear. There's a bony Bankart. And yes, we do those all the time. And usually there's more than just that associated with the problem. There's usually some damage to the labrum. And then there could also be subsequent damage to the cuff and the articular cartilage. But typically the stem cell is not going to heal the Bankart lesion back, but that's usually, we see tons of patients who just have Bankart lesions, have no pain whatsoever in their shoulder, but there's probably something else going on there, and that would be something to take a look at.
Let's see. Would this be effective for contusion of the anterolateral aspect of the proximal tibia? Doing PT for 4 months, but progress has slowed in the past 6 weeks.
So it might be something that would necessitate an MRI to see if there is actually some tearing in that muscle. Definitely PRP, but then if an MRI shows tearing, I probably would do bone marrow and PRP so that we could regenerate tissue. But that would all depend on what the MRI looked like.
Another patient asked how long they have to be off of work. They're on their feet, walking 12 plus hours, walking fast.
I'm assuming we're talking about a knee or a hip. Usually most people, I mean, don't need to be off for more than a week or two. And to be perfectly honest, most people go back the next day. But if you're 12 hours on concrete floors and if you're doing a lot, we might want to take a week.
And let's see. Can the procedure be done if one is on Fosamax due to osteoporosis?
Yes, no problem with that whatsoever.
Someone else asked about a dislocated shoulder. Would this be beneficial?
So for recurrent dislocation, if there's laxity in the shoulder, if there's been some tearing in the tissues that support the shoulder, usually, oftentimes there's a tear in the labrum. And yes, stem cells do definitely improve all that. If it's just a shoulder that continuously dislocates and it's we could call them trick shoulders or whatever. If there's no damage documented on MRI, then stem cells may not be of benefit.
How is this procedure different from hyaluronic acid treatments?
So HA treatments, which is the gel that we inject into, I inject them into all joints, but Medicare only covers the gel for knees. Basically, that is putting Pennzoil 10W40 weight or 10W30 weight into the knee joint. It lubricates the joint. It works in about 50% of patients. It does not regenerate cartilage at all, and you usually need to repeat it every 6 months. I'll do it a lot of times after a stem cell procedure, especially if it's covered by Medicare. You might as well, because there's no downside to it.
Someone asked if an underlying autoimmune issue complicates the procedure at all.
Yeah, we have a lot of patients who have rheumatoid arthritis, lupus, Sjogren's, myositis, all sorts of autoimmune or rheumatological conditions. And I just always explain to them, we're not going to cure the autoimmune disease, but we can definitely treat the affected joint.
Someone said they had a tibia plateau fracture in 2013 and they had pins and a plate in their knee. Can this procedure help with pain and mobility?
Yes, definitely. Because especially if there's a disruption of the overlying cartilage where you had the fracture, most likely, there probably is, and that's what's causing the issue.
Someone asked their ortho PA said stem cell does not work for grade 3 arthritis. Is he correct?
Well, I'll tell you stories about that. Grade 3 arthritis, that's on a Kellgren-Lawrence scale. That's 1 to 4. That's moderate arthritis, moderate to moderately leaning towards severe. I treat tons of those patients. They do incredibly well. Oftentimes, there are a lot of surgeons who poo-poo stem cells. They say it doesn't work. They say it causes cancer. I don't know. I hear the craziest stories. And also, I hear from so many patients, well, I was told I'm bone on bone and I'm not a candidate for anything but a total knee replacement. So we have them bring in their films. We look at the films together. And we say, look at this. You've got adequate joint space. There is nowhere on this x-ray that shows that you are bone on bone. But it is something that a lot of the surgeons like to tell patients. And from what I've come to find out is that the only way insurance will pay for a total knee replacement is if the term bone on bone is in their dictation. So yeah, grade 3, we do them all the time.
Would this procedure help with psoriatic arthritis?
Not curing psoriatic arthritis, but if there are joints that are affected by the psoriatic arthritis, then yes.
Who would not be a candidate for stem cell for osteoarthritic knees?
So infection, if you have infection, if you're undergoing chemotherapy or radiation therapy. Other than that, those are the two big ones. We have patients, God, we had one woman come up from Centralia. She was like, she was basically bedridden because of knee and hip arthritis. She was like 400 and something pounds. She was in a scooter and nobody would touch her, do anything. She's in tears. She said, I can't, no surgeon's going to touch me, do anything. We did stem cells on her knees and her hips. She saw me 3 months later. She was crying because she said, my God, this is the first time in 6 years I've been able to get out of that wheelchair and walk. And she was a large woman, and we had to actually bring in a special table for her, the high-low table, so that we could get her on it and get her off of it. She did. I mean, she's not going to be running a marathon, but she's walking, she's doing activities of daily living, and she's out of pain. This is a woman who said, if I can't get anything done, I seriously contemplate ending my life. So,
Someone asked if the physical therapy is covered by insurance or Medicare.
yeah, physical therapy is covered.
Someone else asked, why are some cases not successful?
Sometimes, and typically, it's not always, but they're older patients, 90, 80, 90 plus with severe arthritis, but maybe they're not candidates for surgery. People who don't, do physical therapy afterwards or who go back to activity too quickly. And it's about 9% of patients. And there's sometimes somebody will come in and have both their knees done and say, Doc, this right knee, it's 100%. I have no pain at all. This left knee is still bothering me somewhat. So sometimes we'll do a PRP booster. In other words, we'll put some more platelets in, or we'll put some HA, which is the hyaluronic acid in. But everything's different. And sometimes we don't know why. I was involved in a study at Ohio State, which it still hasn't come to any conclusions, to see if there was a way. These were some PhD students who were working to see if there's a way, any markers that you could obtain from blood draws to see who was going to be successful and who was not going to be successful with stem cells. But nothing yet. Nothing has come out of that yet.
Someone asked, do women have to wait to discern what is hormonal depletion versus osteoarthritis or synovitis?
No, I mean, definitely hormonal, we can see that on images. So, if there's reason to do stem cells, then yes, we'll see it on the images. If it's just kind of shoulder or hip pain because of, menopausal, or postmenopausal, type syndrome, then that's going to be something we deal with physical therapy, hormone replacement, that type of thing. But with images, we can see if the joint is definitely affected.
Someone asked their MRI on their knee says they're bone on bone, but they don't have pain and they have good function. Should they wait?
No, you want to jump. That's the other thing with stem cells. The earlier you catch the patient in the course of the disease process, the better they do. So, especially with weight-bearing joints, ankles, knees, and hips, because they just get worse quickly because you're walking on them or doing whatever activities. So yeah, definitely that's worth. It may be that there's just one small area that's bone on bone. And that's something that, I need to look at and see on the MRI and the x-rays.
Kind of similar. Patient asked if we treat arthritis in the knee, but they have good cartilage, would stem cell help prevent the arthritis and prevent a knee replacement?
Very much so. A lot of times we'll have patients come in and they say, hey, you know what? This right knee, yeah, I have all sorts of issues. They'll come in the same day and go, can we just take a look at my left? I'm getting a little bit of pain, but I don't want to have issues in 10 years. And so oftentimes we'll have somebody come in that has very mild arthritis. The knee joint looks pretty good. And I'll say, well, up to you. I mean, we're going to do one now. If you want, we can do them both. And oftentimes the patients just say, you know what? I don't want to have any issues in the future. Let's just do them both. So, and that's a conversation that we can have.
Someone asked, is it better to get the procedure earlier after an initial injury in the shoulder or do physical therapy for a while?
It all depends what the diagnosis is. If you've got a tear in the rotator cuff, yes, you want to do it as soon as you can. If there's any osteoarthritis, yes. If there's a big labrum tear, yes. But if it's just a shoulder sprain or a rotator cuff strain or impingement syndrome, then yeah, physical therapy, anti-inflammatories, is certainly a good conservative way to go first.
Someone said they have moderate to severe arthritis in their foot joints, and also the navicular has a bone lesion. They've had PRP, sorry, a week ago. Could stem cell help?
Yeah, I mean, certainly I would say see how it does with the PRP, but if that doesn't do the trick, then the next step is to do bone marrow with PRP.
A few patients are asking if an MRI is like necessary if it's like 2 to 4 years old, but they have more recent X-rays.
Yeah, I mean, sometimes, X-rays tell me everything I need to know. And, I'll tell patients, you've got arthritis in your knee joint. The only options you have are three. One, leave it alone. Two, the only surgery that would be appropriate for you would be a total knee replacement. Or three, do stem cells. And if I do an MRI, the reason I would do an MRI is if it's going to change my decision-making process. And at that point, it's not. So it all depends. If X-rays give me the information that I need, then I don't need any other studies.
Someone wants to know about the cost of stem compared to PRP.
So to do PRP, like for a single joint is what, somewhere around 11
Like
or 12, 1200. To do stem for a single joint, it's 8,000.
Someone said they have an undiagnosed chronic pain in the area of their ribs and muscles on their far right thoracic back. Is that something that could be helped with stem?
Maybe, sometimes where the ribs meet the vertebrae, there's a joint there, just like there is anywhere else, called a costovertebral joint. Sometimes patients can get arthritis in those, and we'll see that on sometimes an MRI, sometimes a bone scan. And that could be something that could be addressed. Oftentimes they do really well, even just with a steroid injection in those areas. So you don't need to go through all the expense and procedure of doing PRP or stem cells.
Someone asked, can stem cell help heal bunion pain?
If the joint is arthritic, which most of the time they are, then yes.
Another person asked, any luck with Lyme disease with an inflamed knee?
Um, Not as far as treating the Lyme disease itself, but if the knee has issues with damage to the cartilage, the meniscus, or inflammation, just synovitis, then yes, either PRP or PRP and stem cells.
Someone asked about consults. Someone said they joined late. Can you explain the difference between PRP versus the stem cell?
So PRP by itself ultimately decreases inflammation. It does not regenerate tissue, whereas stem cells regenerate tissue, whether it be cartilage, muscle, tendon, bone, and then the PRP is like fertilizer for those stem cells.
Someone else said that they're not sure if this is arthritis related or not. They've worked in construction most of their life. Walking isn't a huge issue, but squatting and kneeling and getting up is really hard on them. Is this something that stem cell would work for, or would PRP be better?
And that would all depend on, so yes and yes, or possibly even no and no. It all depends what the images look like. So basic first things first would be X-ray. I'm assuming that we're talking about knees. First thing would be X-ray. That might be all we need to do. Or if the X-rays look okay, then we might move on to an MRI. And then we have the discussion, are you a candidate for PRP? Are you a candidate for stem cells? And kind of what's the difference and what we would recommend.
Someone's asking, is it okay to do a knee and both of their hips at the same time?
We do it all the time.
Someone asked what the cost of a consult is. I can answer that one. Typically, it's between like $300 to $400, and then depending on imaging, that can be a little bit more. But we can bill that to insurance. And then, what is the indicator of success for stem cell therapy on knees? How I feel, or X-rays, or some other measures?
So they did a study at NIH in Atlanta where they have this mega research MRI scanner, unlike anything else in the country. And they did monthly MRIs after stem cell procedures on knees. And at 3 months, they could see statistically significant increase in thickness in the cartilage. I oftentimes anecdotally have patients come back, or I got a call from a radiologist a couple months ago who said, "Hey, Mark," he goes, "I got to tell you, I have an MRI on this gal who you did stem cells on a year ago, and she had a meniscus tear and an osteochondral lesion, and I had to pull the old films. I had to double check the patient's name and date of birth because I couldn't believe it was the same patient because there's no evidence of any issues there now at all." So anecdotally, we see that. We don't routinely get MRIs afterwards because we're looking at PROs, which is patient reported outcomes. We're not treating the film, we're treating the patient. So if patient says, "Hey, I'm back to doing this, I'm 80% better, I'm thrilled, I got less pain, I can do more with less," that's what makes me happy.
Someone asked if they need knee braces after stem cell therapy.
Only if there's significant arthritis such that one side of the joint is narrowing. And if there is, that's like some people are bow-legged, some people have knock knees, and that's because the one side of the joint tends to start narrowing down because the articular cartilage is wearing away. In those patients, we'll put them in these unloader braces, which we send them to a hanger clinic and they get laser measured and they're 3D printed. And there are these great super lightweight braces that help out. But not everybody. No, we don't put everybody in braces.
I don't have any other questions. Does anyone have any questions for Linzy, our physical therapist? Give it a second.
I love to see no questions. Means he did his job.
Right. Oh, someone asked where the physical therapy offices are.
So Linzy is with RET Physical Therapy, which is right at the same place where I am. But RET has, what do you guys have, about 30 locations?
Yeah, I think about 24 locations, as far north as Bellingham and as far south as Puyallup. So we're all across Puget Sound.
Someone had asked if they live out of the area, how do they do physical therapy?
Just where we make it very convenient for where they do it where they live.
Someone said, yeah, Bellingham.
We have one in Bellingham.
Well, there you go.
There we
go.
go.
Just another like spinal conditions.
Yeah, I mean, I look at spine, I treat spine all the time, but if it's something that necessitates doing stem cells, I do usually refer you off.
Someone just asked if we can answer questions here, or they also emailed their questions. I can answer your questions via email as well. Oh, does it require special physical therapists to prescribe stem cell recovery exercises?
You know, Linzy, I'll let you handle this one because you treat.
Yeah, no. Obviously, it is better to have someone who's experienced with stem cell. It's not something they necessarily cover in physical therapy school. I'm board certified orthopedic clinical specialist, and I do think that board certified orthopedic clinical specialists handle it better. But there's not a specific specialty for physical therapist.
I don't see any other questions, guys.
All right. Thank you, Linzy, for us.
Yeah,
Thanks,
thank
John
you.
Curley, if you're still on. And you all have a good evening. If you need anything, certainly you can call to schedule consults here and Chelsea and Ani at our front desk. And we can usually get people in within what, a couple weeks for consults and within a couple weeks usually for procedures. All right. Well, thank you all. You all have a good evening.